Welcome back to UTI Part 2. Our last sketch covered the workup of UTI, and now it's time to do something about it. Let's review the assessments we discussed in the last sketch for cystitis, pyelonephritis, and prostatitis, starting with cystitis. Ms. Coli is a 24-year-old woman with no significant medical history, presenting to her primary care physician with several days of dysuria and increased urinary frequency. She denies vaginal discharge or bleeding. Of note, she is in a monogamous relationship and uses condoms intermittently during sexual intercourse. Vitals are within normal limits. Physical examination reveals mild suprapubic tenderness, but is otherwise unremarkable, with no costovertebral angle tenderness. No diagnostic testing was performed. In light of her clinical history and these objective findings, her diagnosis appears to be simple cystitis. And how about that pyelonephritis patient? Ms. Klebb is a 46-year-old woman with past medical history of diabetes who presents to the emergency department with severe right-sided flank pain for the last 24 hours. She also reports 3 days of dysuria, urinary urgency, and subjective fevers prior to the onset of pain. She is febrile. Physical examination reveals exquisite tenderness to light palpation of the right costovertebral angle. Urinalysis reveals evidence of leukocyte esterase and nitrites, and there is a neutrophil predominant leukocytosis on CBC. Given her clinical history and these objective findings, her diagnosis appears to be acute pyelonephritis. And finally, acute prostatitis. Mr. Preston is a 63-year-old man with past medical history of hypertension and BPH who presents to the emergency department with dysuria, increased urinary frequency, urgency, and pelvic discomfort. He is not sexually active. He is febrile. Physical examination reveals no suprapubic tenderness or costovertebral angle tenderness. Rectal exam reveals an edematous and tender prostate. Urinalysis reveals evidence of leukocyte esterase and nitrates, and there is a neutrophil predominant leukocytosis on CBC. Given his clinical history and these objective findings, his diagnosis appears to be acute bacterial prostatitis. Oh yeah, the whole gang's here. Simple cystitis over in the booth, sipping that bladder beverage, pyelonephritis down in that pylo pina colada, and prostatitis. What a klutz. Right on the prostate. You better clean up after yourself, Bruno. Ha ha. Probably slipped in all the grease he put in that jelly roll. Anyways, you might recall from our last sketch that non-pregnant, otherwise healthy women with classic symptoms of cystitis and no scary risk factors can be treated empirically without a need for diagnostic testing. That's pretty simple, just like simple cystitis. In general, if your patient doesn't fall into the simple cystitis category, get labs. This includes patients with those risky factors we talked about last time. You know, those factors like diabetes, anatomical abnormalities, or catheter use, which not only increases the risk of getting cystitis in the first place, but also increases the risk of extension beyond the bladder, as well as extra complications. Also consider risk factors for multi-drug resistant bugs, including recent broad-spectrum antibiotic use, inpatient stay at a healthcare facility, or recent travel to areas with increased MDR bacteria. And really, just anyone with atypical features, or signs that the infection has spread beyond the bladder. We're talking pyelonephritis, prostatitis, or sepsis. Patients who don't fall into the simple cystitis category need further testing, starting with a urinalysis. In the setting of UTI, urinalysis will almost always demonstrate pyuria, which is the presence of white blood cells in the urine. Most UTIs will also demonstrate the presence of leukocyte esterase on dipstick, an enzyme produced by leukocytes. Nitrites indicate the presence of Enterobacteriaceae specifically, such as E. coli. Also, when we're not dealing with our super simple cystitis cases, urine cultures are generally warranted to guide antibiotic therapy. Urine gram stain may also be ordered to help you spot those gram-positive bugs, like Enterococcus and Staphylococcus. This helps us choose empiric antibiotic therapy. Treatment time! In general, UTIs are treated empirically with antibiotics. The goal is to use patient demographics and risk factors to select an antibiotic or antibiotics that will cover the bug most likely to be causing infection. We'll first tackle treating cystitis in the outpatient setting. So let's peruse the takeout menu, shall we? Remember that therapy for outpatients generally means oral antibiotics. Before we get into the treatment of pyelo and prostatitis, let's keep it simple. For simple cystitis, the first-line antibiotics are generally trimethoprim sulfamethoxazole for 3 days or nitrofurantoin for 5 days. Depicted on the menu by the $3 sulfa eggs and, for that morning's pick-me-up, $5 nitro coffee. Fosfomycin, given in a single dose, is another option, though it is generally considered second line due to increasing rates of resistance. So if the nitro coffee just isn't doing it for you, they got fosfomycin faucet water with natural minerals. Does lead count as a mineral? Remember, that's 1 dose per customer. These drugs will cover the usual urinary tract culprits, including Staph saprophyticus, Proteus, E. coli, and Klebsiella, which we abbreviate with the acronym SPEC. These empiric agents also cover a couple gram-positive urinary bugs, Enterococci and Staph aureus, symbolized by the enter rock drums and the staph picture on the menu. Notice that the rock drums are purple for gram-positive and reflect the classic diplococcus shape of Enterococcus. Staph aureus and Enterococcus are especially prevalent in patients with a recent hospital stay or broad-spectrum antibiotic exposure. For cystitis with risky factors, those factors like diabetes, anatomical abnormalities, or catheter use, which not only increases the risk of getting cystitis in the first place, but also increase the risk of pyelonephritis as well as complications of pyelonephritis. Those patients treat with trimethoprim sulfamethoxazole or nitrofurantoin for longer. 7 days is usually the recommended therapy. Same drugs, same bugs, just longer treatment. For male patients with simple cystitis, it is also reasonable to treat for 7 days. Men and their long urethras. Typical. What about in patients who have risk factors for infection by multi-drug resistant microbes? Remember, these risk factors include recent hospital stay or antibiotic use. For empiric treatment, rely on what's highlighted in the box here, either nitrofurantoin for 5 days or 1 dose of fosfomycin. Both will target Pseudomonas and extended-spectrum beta-lactamase-producing E. coli, as well as fluoroquinolone-resistant E. coli. All right, that's it for cystitis. Next up, pyelonephritis. Let's mosey on over to Mr. Cool Pineapple Man and his lady friend. Pyelo can get a little crazier, but there are occasions when you can indeed treat pyelo in an outpatient setting. These are patients with pyelo of mild to medium severity who are easily stabilized with fluids and antibiotics. Make sure to have close follow-up to ensure completion of their PO antibiotic regimen. Empiric antibiotics for pyelonephritis should always cover gram-negative bugs, particularly our favorite friend, E. coli. If urine gram stain demonstrates gram-positive organisms, add gram-positive coverage as well. Pyelonephritis in patients without risk factors for multi-drug resistant organisms can be treated with oral fluoroquinolones as monotherapy, symbolized as usual by a fluoroquinolone flower. Notice that the stem is in the shape of the number 7, as in 5 to 7 days of treatment. Specifically, we treat with ciprofloxacin or levofloxacin, hence the phrase, leave me a sip. Cipro and Levo specifically provide coverage for Pseudomonas, which is why we've brought back Mona Lisa on the menu. In general, fluoroquinolones have lots of gram-negative coverage, perfect for destroying E. coli and its gram-negative Enterobacteriaceae friends. So, the overall theme of this floral female patron is red. That's red for gram-negative. Notice that we've also sprinkled a purple flower here and there as a subtle reminder that fluoroquinolones also have some gram-positive coverage against Staph saprophyticus and aureus, for example. Patients receiving fluoroquinolones should be aware that the drug can cause tendinopathy and even tendon rupture, most frequently involving the Achilles tendon. The drug should be discontinued at the first sign of tendon pain or swelling. Next to our lady in tropical garb, we have a pretty tough-looking guy wearing a pretty tough-looking biker jacket. He's here to remind us of patients at risk for multi-drug resistant organisms. You know, recent hospital stay or recent antibiotic use, etc. Those patients should receive a one-time dose of an IV or IM carbapenem, specifically ertapenem, prior to starting the oral regimen. Just take a look at his hat. Carbapenem is the car, ertapenem is the hurt. After that, proceed with your 5 to 7 days of oral fluoroquinolones. Adding ertapenem covers extended spectrum beta-lactamase producing E. coli and fluoroquinolone-resistant E. coli. So, we've added an extended spectrum belt and glass of E. coli to this ertapenem hat guy. No thanks, E. coli. Notice the theme here. Whenever a patient comes in with risk factors for multi-drug resistant organisms, the two big microbes we need to worry about are Pseudomonas and extra-resistant E. coli, symbolized by Mona Lisa and that rainbow spectrum E. coli. In the setting of cystitis, nitrofurantoin or fosfomycin did the trick. In the case of pyelo, fluoroquinolones kills the Pseudomonas, while ertapenem kills those resistant E. coli. Ertapenem bringing the hurt-a-penem, huh? All right, when should you admit the patient instead of pursuing outpatient treatment? Well, if your patient is septic or critically ill, that's an easy one. Admit. Otherwise, we typically consider inpatient management with persistently high fevers or pain, marked debility, or inability to maintain hydration or take oral meds. Also, if you're thinking they have an obstruction, inpatient it is. For inpatients with pyelo who don't have risk factors for multi-drug-resistant bugs, first-line treatment is usually one of the following. IV ceftriaxone, symbolized by the axe, IV piperacillin tazobactam, symbolized by the piper with tambourine, or thirdly, PO or IV fluoroquinolones, specifically ciprofloxacin or levofloxacin. Again, fluoroquinolones are symbolized by the flower. These options give good gram-negative coverage. Think E. coli and other Enterobacteriaceae like Klebsiella and Proteus. These regimens also cover some gram-positives like Staph saprophyticus and aureus. So we've got a fuchsia and purple theme running throughout. Lots of red for lots of gram-negative coverage, along with some purple for some gram-positive coverage. Keep in mind that fluoroquinolones and piperacillin also have activity against Pseudomonas, which is important to consider in patients with previous UTI from Pseudomonas or current febrile neutropenia. We'll get way into febrile neutropenia in its very own sketch, don't you worry. Now, before you decide on the optimal empiric regimen, you gotta think about gram-positive bugs as well, and a urine gram stain helps. Gram stain, remember, is embodied by a painter, a stainer, if you will, throwing some purple up on the wall. That's purple for gram-positive. Patients with gram-positive cocci on gram stain or patients with a history of UTI with gram-positive isolates need gram-positive coverage. Specifically, we want to make sure that Enterococcus is covered. embodied yet again by those purple diplococci rock drums. In this case, pipe tazo is the empiric therapy of choice, since it has good activity against Enterococcus. And fittingly, in the painting, those rock drums are being accompanied by the pipe tazo pipes and tambourine. And finally, we need to consider risk factors for multiple drug-resistant organisms, recent hospital stay, recent antibiotic use, etc. You know the drill. Yet again, these risk factors are represented by that intimidating resistance jacket. These patients should be treated with an anti-pseudomonal carbapenem for empiric therapy, in particular, imipenem, meropenem, or doropenem. What bugs do we need to cover when we encounter the potential for multi-drug resistance? That's right, Pseudomonas and extended-spectrum beta-lactamase-producing E. coli, our fastidious friends. Inpatient treatment of pyelonephritis with risk for multi-drug resistance will be treated with an anti-pseudomonal carbapenem. Outpatient treatment of pyelonephritis with risk for multi-drug resistance will be treated with fluoroquinolones against Pseudomonas and ertapenem against those resistant E. coli. And over on the left, treatment of cystitis with risk for multi-drug resistance involves nitrofurantoin or fosfomycin. Pseudomonas. More like pseudo no thank you or pseudo no mas. Yeah, you get the idea. One last stipulation. Again, we're focused on those patients with pyelonephritis and risk of multi-drug resistant microbes. This time, if the gram stain comes back positive, you are not just worried about Enterococcus and staph, but resistant Enterococcus and staph. We're talking MRSA and vancomycin-resistant Enterococcus, or VRE. Give vancomycin to cover MRSA, as depicted by that no mercy van. In the case of VRE, give daptomycin or linezolid, as depicted by the department line around the picture of rock drums. They'll cover MRSA too, by the way, so win-win. Hey, we did it! We treated cystitis or pyelonephritis in your patient with or without risk factors for resistance. Give yourself a pat on the back. Don't get too comfortable, though. Let's say your patient with pyelonephritis has persistent symptoms after 2 to 3 days of treatment. What next? Well, if our recurring black cat symbol is any indication, I'd say it's time for a CT scan of the abdomen and pelvis. What we're looking for is obstruction, such as an obstructing stone or complications of pyelonephritis. These include renal or perinephric abscess, emphysematous pyelonephritis, or papillary necrosis, each symbolized at the boot in the back. All right, time to wrap this thing up with our last type of UTI, prostatitis. Take a look at this suave dude who just took a nasty spill right on the prostate. In the outpatient setting, with no multi-drug resistance risk factors, prostatitis involves a lot of the same bugs we encountered with cystitis and pyelonephritis. So our coverage is the same. Your options are PO, trimethoprim sulfamethoxazole, or a fluoroquinolone, usually ciprofloxacin or levofloxacin. This regimen will cover the usual gram-negative suspects, such as E. coli and other Enterobacteriaceae. On top of that, we've got some gram-positive coverage, namely Staph aureus and Saprophyticus. And hey, if you choose the fluoroquinolone, you'll cover Pseudomonas too. If you take a close look at his hair, behind all those layers of grease, you'll see the number 6. Prostatitis is typically treated for 6. That's right, I said 6 weeks. Just gotta marinate that prostate for a while. Let it penetrate the gland. Like in pyelo, prostatitis patients who require inpatient management are given IV antibiotics instead of oral ones. Same bugs, new route. With some variations here and there, inpatient strategies are pretty similar to pyelonephritis and won't be covered in this sketch. Keep in mind that sexually active men, who are often, but not exclusively, young, are at risk of prostatitis caused by Neisseria gonorrhea and Chlamydia trachomatis. If you're suspicious for these bugs, you can treat with a dual regimen: 1 dose of ceftriaxone and 1 dose of azithromycin, symbolized on the back of his badass biker jacket for the 3-axe gang. That's 3 axes for ceftriaxone and a crow for the macrolide azithromycin. If it's all right with you, let's make our way out of that cramped prostate and back into the urinary tract. As we discussed earlier, UTIs can be painful. If a patient presents with dysuria, they may benefit from phenazopyridine, a urinary analgesic, represented here by this pain-relieving phenazopyridine fizzy drink. It can be used alongside the usual antibiotics and is typically given for a period of 2 days. When using phenazopyridine, it's important to warn your patients ahead of time about the side effects, namely that it can turn their urine orange. This is a benign effect and resolves with treatment cessation. Another important consideration: if a patient with an indwelling catheter develops a UTI, change the catheter. Ideally, these should be exchanged regularly, regardless, but the presence of a new infection warrants immediate replacement, and consideration should be given to ongoing necessity of the device. In patients with recurrent simple cystitis, defined as 3 or more cases per year, or 2 or more per 6-month period, it may be appropriate to initiate prophylactic antibiotic therapy. This can take many forms and may involve postcoital oral antibiotic administration or continuous dosing. A regimen of trimethoprim sulfamethoxazole is common, though numerous other antimicrobial regimens can be used based on the susceptibility patterns of the strains causing the recurrent UTI. In men, further urologic workup is not needed for the first UTI. However, men who have more than 1 UTI should be worked up for chronic prostatitis, BPH, or other causes of urinary tract obstruction, especially if the same strain of bacteria is isolated every time. It could be chronically leaking from that prostate. Side note, what if a urine culture is clearly positive? We're talking over 100,000 colony-forming units per high-power field of bacteria. But your patient has no symptoms. This is considered asymptomatic bacteria, not a UTI. This should only be treated in pregnant women, patients with a transplanted kidney, or patients undergoing urinary tract procedures. Everyone else, don't treat. The specific medications used to treat UTIs and asymptomatic bacteria in pregnancy will be covered in our upcoming Sketchy OB course. All right, it's closing time, and that means sum-up time. Non-pregnant, otherwise healthy women with classic symptoms of cystitis and no risk factors for resistance or complications can be treated empirically without the need for diagnostic testing. Everyone else gets labs, usually urinalysis and culture. In general, UTIs are treated empirically with antibiotics. For simple cystitis, choose PO trimethoprim sulfamethoxazole for 3 days, nitrofurantoin for 5 days, or, as a second-line option, 1 dose of fosfomycin. These cover SPEC, which is comprised of Staph saprophyticus and the Enterobacteriaceae such as Proteus, E. coli, and Klebsiella. These also cover Staph aureus and Enterococci. For cystitis with those risky factors, treat with the same drugs for longer, usually 7 days. Same goes for men with cystitis. Worried about multi-drug resistant risk factors in cystitis? Choose PO nitrofurantoin for 5 days, or, as a second-line option, 1 dose of fosfomycin. This will cover ESBL, E. coli, and Pseudomonas, as well as fluoroquinolone-resistant E. coli. Moving on to pyelonephritis. For some cases, you can treat this in an outpatient setting too. Treat pyelo without multi-drug resistant risk factors with PO fluoroquinolones, specifically ciprofloxacin or levofloxacin for 5 to 7 days. This covers lots of gram-negatives such as E. coli, other Enterobacteriaceae, and Pseudomonas, and some gram-positives such as MSSA. If multi-drug-resistant risk factors are present in outpatient pyelo, first give 1 dose of IV or IM carbapenem, specifically ertapenem, prior to starting that oral regimen of 5 to 7 days of fluoroquinolones. This will target ESBL E. coli as well as fluoroquinolone-resistant E. coli, while that fluoroquinolone takes care of Pseudomonas for you. Moving on to inpatient pyelonephritis. As you can imagine, you'll want to use IV antibiotics rather than PO ones. For inpatient pyelo with no multi-drug-resistant risk factors, you have 3 options: IV ceftriaxone, IV piperacillin tazobactam, or a fluoroquinolone. This will cover lots of gram-negatives such as E. coli and other Enterobacteriaceae, and some gram-positives such as MSSA. When Pseudomonas and her enigmatic smile are of concern in inpatient pyelo, use a higher dose of piperacillin tazobactam or a fluoroquinolone. If you're likely dealing with a gram-positive case of inpatient pyelo, treat with IV piperacillin tazobactam to cover Enterococcus. If you suspect those gram-negatives are getting cocky and develop resistance factors, treat your inpatient pyelo patient with an anti-pseudomonal carbapenem, specifically imipenem, meropenem, or doropenem. This will cover ESBL E. coli and Pseudomonas, as well as fluoroquinolone-resistant E. coli. You might suspect those gram-positives have developed resistance factors, say VRE or MRSA. Either add vancomycin for MRSA or add linezolid or daptomycin for both VRE and MRSA coverage. Get a CT if your patient's pyelo symptoms have persisted despite 2 to 3 days of antibiotics. Specifically, we're trying to look for obstruction and complications of pyelo like abscess, emphysematous pyelo, or papillary necrosis. Finally, we move to prostatitis. In the outpatient setting, where patients have no multi-drug-resistant risk factors, cover for those same bugs we saw in cystitis and pyelo. You can treat with PO trimethoprim sulfamethoxazole or fluoroquinolones, Cipro or Levo. But don't forget the hair. Treat for 6 weeks instead. All right, what if you see a prostatitis patient and you know they're sexually active, very active? Make sure to think about gonorrhea and chlamydia. Treat with 1 dose of ceftriaxone and 1 dose of azithromycin. Do both. If your prostatitis management needs to be escalated to the inpatient setting, but there are still no multi-drug-resistant risk factors, use an IV fluoroquinolone. And remember, for resistant bugs in inpatient prostatitis, make like pyelo. Same treatment regimens. Gram-negative, treat with anti-pseudomonal carbapenems, just like pyelo, for the same bugs as in pyelo. Gram-positive resistors, add on your Vanc, Dapto, or linezolid. For all UTIs, phenazopyridine can be helpful to treat dysuria. Warn patients about their urine temporarily turning orange. Also, change any indwelling catheters if a UTI has developed. If this isn't the patient's first UTI, specifically 3 or more per year, also known as recurrent UTIs, you'll want to consider prophylactic antibiotics. In men, if they've already had 1 UTI before and they're presenting with yet another one, you need to work them up further for things like chronic prostatitis and BPH. Lastly, one special case. You might see a patient with a positive urine culture for bacteria, but no symptoms of a UTI. Only treat this in pregnant women, patients with a transplanted kidney, or patients undergoing urinary tract procedures. No one else. Hey, Bruno, get off of your keister and hit that jukebox. Man, those sounds are really razzing my berries. Hey, Mona, leave me a sip, will ya? Come on, Snake, let's rattle. What's a guy got to do to get a pilo colada around here? Man, this place is nowhere to go. Let's split. Oh, Bruno,